All right. Good evening, everybody. First off, I want to tell you how much we appreciate you joining us, taking part of your evening to be with us here. My name is Diane. I'm one of the technicians for the doctors here. We are expecting just a few more people to join us, but we'll go ahead and get the ball rolling. First off, I want to tell you a little bit about what we do here. Refractive surgery is what we specialize in, and tonight you'll be learning a lot about significant contributions Dr. MacRae has made to the industry, such as developing instruments and software that only our office has access to. So he really is the master of refractive and LASIK surgery. We will be doing a quick tour of the facility and a Q&A session at the end. If you'd like, you can drop in your questions in the chat or the Q&A box, and we'll try and tackle them as we go. First, I'm really excited to introduce to you Dr. Kenneth Dickerson. He is our senior clinical instructor here. He is a leader in his field. He lectures other optometrists, belongs to a few different optometric societies. He went to SUNY Geneseo, graduated in 2002, on to the New England College of Optometry, graduated in 2006. He was personally handpicked by Dr. MacRae to be part of our team here. Dr. MacRae does consider him one of the best optometrists he's worked with. Dr. Dickerson does about 80% of our consultations here. That does focus, help Dr. MacRae focus on customizing your surgery for you. So Dr. Dickerson does a bulk of all the follow-ups as well. When Dr. Dickerson is not with us, he enjoys spending time with his wife, his daughters, he's got dogs, he's got cats. He likes to bike, swim, garden, he coaches swimming as well, he bakes, he does everything. And he's also had refractive surgery himself, so he does understand questions and concerns you have going into it, so he's a great wealth of info. Oh, and he does love to wear crazy socks, so just take a gander at his socks, his ankles when you come in here. So now we'll introduce Dr. Kenneth Dickerson. He'll tell you just a little bit about your eyes today.
All right. Well, I want to thank Diane for that wonderful introduction. And I want to give you a little bit more information about who we are, what we do here at the University of Rochester's Refractive Surgery Center. We're certainly part of the University of Rochester's Flaum Eye Institute. Formerly, the practice was known as Strong Vision. And the only thing that our practice really specializes in is vision correction surgery. And then we're going to talk about our two main surgeries this evening. But we've been really doing this for over 25 years. And we're fortunate to have Dr. MacRae come to Rochester to work with some of our researchers in the optics teams that we have across the university to actually help improve upon laser surgery. Now, certainly there is a teaching mission that does occur along with being part of the University of Rochester. So there will be residents and fellows that are shadowing either myself or Dr. MacRae. But certainly if I'm doing your evaluation, Dr. MacRae is going to be your surgeon. So we work it that way. They come and we help them get educated and learn about the process. But when it comes to the actual doing of the procedure, you're in wonderful hands with Dr. MacRae. So let's talk a little bit about your eyes at this point. So how is the eye supposed to work? Well, very similar to a camera. Light is supposed to come into the front, it's supposed to get focused and go to a detector. But in case of the eye, that detector is your retina, which then sends that information to your brain and you have vision versus going on to a digital drive in your camera. So, but thinking of it that way is very important. Light is supposed to come in, get focused, and actually be clear as an image. Now, when that's not happening, that's when you don't have a perfect eye. That's when you actually have a refractive error or a need for glasses, and that exists when the vision is not coming into that crisp, tight focus at the back of the eye. So we certainly have to, have some names for these different types of refractive errors. One of the most common ones that we are treating is nearsightedness or myopia. And with myopia, the light is coming into the eye and it actually isn't focusing all the way to the back of the eye. So it's not making it all the way back to the retina. And the exact opposite of that is farsightedness. So farsightedness light is actually not focused strongly enough. So it's actually coming into focus well beyond the back of the eye. And both of those need glasses or contact lenses to correct. The last one is astigmatism. And with astigmatism, we're showing the light actually focusing in two different positions. The reason we're showing it focusing in two different spots is because of the curvature of the front surface of the eye can be much steeper in one area, much flatter in another area. and that can create a splitting of that focus. Now, the interesting thing certainly with astigmatism is that it can be included with nearsightedness. It can be included with farsightedness. Somebody can be nearsighted with astigmatism, farsighted with astigmatism, or every so often we have some patients that just come in and have astigmatism only. The interesting thing with astigmatism is it will affect the quality of the vision at all ranges, versus those that are nearsighted generally are able to see something fairly well close. Those that are farsighted do, certainly better at distance. But those with astigmatism have a blur really kind of at all ranges. And those are the things that will affect your distance vision. Now, certainly there are other things that can be going on with the eyes, and we're going to talk about one. This happens with the aging process of the eye, and really the issue here is that the lens inside the eye as we age becomes more rigid. It's not as flexible, and it can't do the work that we need it to, so that we can see things that are very close to us. That's why I have that gentleman there with showing the very long arms holding that book very far away. So that lens gets thicker, it can't zoom in, and then we need some sort of correction for that. And this typically happens in the mid 40s. A little bit of variation one way or the other, depends on quite honestly depends on how you age. But the thing we don't have is we don't have any one definitive surgery that's going to actually correct for that need of that lens not being able to zoom in. So we typically end up needing reading glasses, magnifiers, bifocals, multifocal contact lenses, progressive lenses in our glasses, something to help us be able to actually do that work up close. When it comes to our surgeries, we still would expect patients to need readers and magnifiers to help them see things up close once they get to that age. So say somebody has surgery in their 20s. I do not expect them to need reading glasses right after the surgery. I do expect them to need reading glasses sometime by the time they're in their mid 40s, because they've aged into it. If somebody's coming in to see us for their first time evaluation and they're in their mid 40s, or their 50s or their 60s, then absolutely have to expect you're going to need reading glasses after the procedure, because again, our goal is to correct distance vision. That need for the up close vision, that comes from a part of the eye we're actually not working on. So yes, would still be needed. So I hope that makes sense. Our goal is to get that good quality distance vision, and from a standpoint of where distance vision starts, kind of really think about the distance from your dashboard in your car and out. That's our goal, to make that clear. Anything closer than that, as we age into needing reading glasses, we'll start to need some help with those things. All right. So since we are here to talk about refractive surgery, I thought I might spend a moment to actually talk about my refractive surgery, so you get a little bit of understanding of what we can actually treat, what range we can work with. So this was actually my previous prescription, and that top row is my right eye, the bottom row is my left eye. So if I were to click the boxes of what type of prescription I had, I was nearsighted with astigmatism. I had more nearsightedness in my right eye, hence the minus 6.5, less in my left eye, the 2.5 in that first column. That's my amount of nearsightedness. So how does all of this matter or fit in with what we're thinking about? Well, we can treat certain ranges of prescriptions. So for those that are nearsighted, all their prescriptions have that little minus sign in front of them, and we can treat about 10 units of nearsightedness, or a minus 10 on the surface, if we've got enough tissue to work with. For those that are farsighted, the range is a little bit shorter. We can treat about 4 units of farsightedness on the surface. So if you've got a prescription, if you're farsighted listening tonight and your prescription is +4 or less, that's a great spot. If you're listening tonight and you're nearsighted, we want to see that minus 10 or less. That puts you in kind of a good starting spot. For those that have astigmatism, and I realize not everybody does, we can treat about 4 units of astigmatism. And so for myself, I had 1.75 in my right eye, 2.75 in my left eye. It's a little difference between my eyes, obviously, but both were still very treatable. Now, the last column for the prescription just tells us where the astigmatism is located. Doesn't matter what that number is. So that one doesn't. That one is, we can treat any astigmatism in any axis, is what it's called. So that, if you've got your prescription close by and you want to take a peek at it, that's a wonderful thing to kind of, think that +4, everybody wants to be 0 down to that -10. Our goal is to make sure that we're within that range. If you are initially, well, then that generally means it's a good idea for us to come in, do the full evaluation, and make sure that you're in range. Now, if you're sitting there looking at this going, hey, I'm not within these ranges, well, keep in mind we're talking about just LASIK and PRK tonight. There are other procedures. Let one of our patient educators know, and we'll make sure we get you in for the proper type of evaluation, but you should really most likely still come in for an evaluation. Now, we realize not everybody likes to wear glasses. That's totally fine with us. And that's one of the reasons that we do this, so that we can help those that are having trouble wearing glasses, wearing contact lenses, find alternatives. So hopefully get you all in for evaluation. All right, so now it's my pleasure to actually introduce Dr. Scott MacRae. He is our surgeon, and not only that, he's also a professor of ophthalmology and visual sciences at the University of Rochester. Over the years, he has helped improve upon the technology of refractive surgery in leaps and bounds, and as so has been a member and consultant with a number of FDA panels to help get devices and procedures approved, has consulted with multiple laser companies to help them move their technology to the point where it's actually usable and improved, and has designed and patented multiple surgical instruments and techniques on his own. He's going to actually talk about one of those tonight, and because it has had really big ramifications on how we're actually able to improve refractive surgery. Now, along that way, he's written not only one but 2 books on custom LASIK. Now, these are a big deal for those of us that study of all of this, but very important in what it did for really the procedure. It's not required reading for any of you. And in 2003, he was actually awarded a very prestigious award, Lanz International Award, which is really kind of recognition for all of that body of research that he had put into all of this at that point in time. And of course, he had to go and one-up himself. In 2017, he was actually awarded the highest award in refractive surgery. Now, that's a really big deal, not only because I can fill the entire screen with the size of the award, but what it actually represents. There's about 200,000 ophthalmologists practicing worldwide currently. There's about 20,000 that do refractive surgery. And at the time Dr. MacRae had been awarded this, there had only been 32 other individuals so recognized over the years. So we certainly applaud his recognition with all of that. And again, he does actually personally design and perform all of the surgeries at the Eye Institute. So without further ado, we'll bring Dr. MacRae in so that he can take you through what LASIK and PRK is all about. And as always, Dr. MacRae will end up muting and going and then giving you remote control.
Thank you, Dr. Dickerson, for that nice introduction. I'm Dr. Scott MacRae. I'm going to talk to you about some different types of refractive surgery. The most common by far is LASIK. It accounts for about 80% of the procedures we do. It's called laser-assisted in situ keratinobleusis, and you won't be quizzed on that, so don't worry. We call that the flap surgery, where we actually create a flap and then lift the flap and then reshape the cornea with the excimer laser. That the cornea heals very, very quickly after that, usually within the first few minutes. It's sealed down, and we'll have the patient go home, close their eyes for 8 hours. And typically those patients can, when they come back the next day, they can see and they're functioning, they get back pretty much to normal activities within 24 hours. The other procedure we typically do in about 20% of cases is PRK. It's used for patients with thinner corneas, some surface abnormalities, and we call that the surface procedure. When we do that, we actually take the surface layer off, reshape the cornea with the same excimer laser, and then put a banded soft contact lens on. It usually takes 3 to 5 days for that to really settle down and for the vision to recover within the first week. Both procedures are performed with the same excimer laser technology, and typically they have the same end result in terms of safety and efficacy. We've actually done large clinical trials where one eye is done with PRK, the other eye is done with LASIK, and the same patient. And when we compare the results at 1 month, they're exactly the same in terms of safety and efficacy. So, well, LASIK has been around for over 30 years, and it's used to treat nearsightedness, farsightedness, and astigmatism. And as I mentioned before, we actually create a thin flap, as you can see in the upper left here, and then reshape the cornea with a laser beam, and then put the flap back into position. The flap is actually created with a separate femtosecond laser. This is the Zemer femtosecond laser. Femto means 10 to the minus 15th, which is a billionth of a millionth of a second. And so there are literally millions of pulses that go in into the cornea. It creates a very, very fine bubble layer. And all I have to do is just lift the bubble layer. So we're not actually cutting anything. All we're doing is just separating the tissue plane. Then we go ahead and put the flap back into position. It osmotically seals. My background is as a cornea physiologist. And for years, I wondered how it actually works. And it's similar to when, let's say, you have a spaghetti noodle that's wet and you throw it onto a wall and let it sit for about 20 minutes, and then you come back and you actually lift it off and the wallpaper comes off. It's that same type of osmotic sealing. Both eyes are typically treated on the same day, and the visual recovery is actually very rapid. We use several different lasers. We actually are a refractive center, so we're specialized in this. So we actually have more than one type of excimer laser. We typically use the Bausch & Lomb Optic 217Z laser or the Vuzix I design. I actually have participated as with the early development of the Bausch & Lomb 217Z laser and helped develop much of their software and hardware. So we're very familiar with this. These are both state-of-the-art, high-speed flying spot systems. They're highly accurate, very, very accurate in my hands because I actually developed some of the software and the nomograms basically to do the corrections. And we'll talk about that a little bit later. They use an iris recognition system, and you can see on the lower right, these two little antennas here. Those are infrared lights that basically are shined onto the iris, and the other eye is actually covered. And the infrared lights are shined onto the iris, and that actually picks up the iris image. It can actually, it's like a fingerprint actually, but any kind of micro movement, the laser will actually detect and move with the eye. It'll shut off if the eye moves more than 400 microns. And so I'm actually fussier than the laser, so I'll actually shut the laser off. I actually take my foot and pull off the pedal, as you can see here, and take my foot off the pedal, get the patient realigned, and then go ahead and resume treatment. My team has basically worked with the development of the Bausch & Lomb laser system, and we actually work together on new laser technologies as well. We're actually working on another program for a sort of a next generation laser, but the current generation lasers in the right hands are extremely accurate for about 98% of patients that qualify. So this is an actual procedure, and we're going to activate the video. So this is an actual procedure. Before the procedure, I'll sit down with the patient, basically explain what they're going to experience. I don't go into a lot of detail, but enough that you know what you're going to be experiencing. I've had the procedure, Dr. Dickerson's had the procedure. So we go through and make sure that the patients understand the procedure. If you want some Valium before the procedure, we can give you that. Then I go back and forth with my technician. I'm like a pilot with a co-pilot. She doesn't trust me, I don't trust her. We go back and forth over 2 pages of numbers, make sure those are right. If they're not, I'll actually go back and measure, do the measurements myself. Then we have the patient lay down, and we give a series of 3 sets of drops, some anesthetic drops. So the eye's nicely anesthetized. And during the actual procedure, I'm actually looking through an operating microscope so I can see any micro movement. You can see me actually adjusting the little toggle, and that allows me to get really fine centration with the excimer laser. During the procedure, the patient actually doesn't see or feel anything, but you can see the blue dot kind of spinning around. and that's the excimer laser actually reshaping the cornea. Then we go ahead and get the flap back into position, and then we dry it and make sure that it's aligned exactly right. And then after the procedure, I'll have the patient sit up. This patient was very, very nearsighted, so when she sat up, she actually looked at the clock, and she could tell right away that there was a pretty dramatic change in her vision. Then I'll go ahead and make sure that everything is exactly the way I want. And then we'll put a pair of goggles on and then ask the patient to go home, close their eyes for about 8 hours. You can be up for bathroom and meals, but the more you keep them gently closed, the quicker that tearing and burning kind of fades away. Okay, so we're done with that part. So, well, how do we actually do this? This is actually a human hair on the right, and during the actual procedure, you'll hear like a, which is basically 100 computer-controlled pulses of ultraviolet light per second, and that's what's actually reshaping the cornea. And each pulse is about 1/4 micron, so it's a very minuscule amount. But I literally can reshape the cornea with those fine pulses. We may do 3,000 or 4,000 pulses to actually do the reshaping that we want. So we can get very fine control with that very fine pulse energy. The typical laser treatment takes less than a minute, usually about 20 to 40 seconds, and the entire surgery in my hands takes about 6 to 8 minutes. So once we get going, things move very quickly. We don't talk about, whether the Bills are going to beat the Kansas City Chiefs or not, or whether the Sabres will ever make the playoffs. We're very focused. The whole team that we work with is highly experienced, and we move right along. So like any procedure, there are risks with LASIK and PRK, and typically patients get some dry eye. This happens in virtually everybody. So we encourage you to take some artificial tears in that early post-op period, but the dry eye fades away usually within the first several weeks. In addition, you'll get some glare and halos, which is related to the dry eye typically, as well as some fluctuating vision, again, related to the dry eye. Approximately 5% of patients may require retreatment afterwards to refine their vision. In one study we did on 1,088 eyes, 60 eyes did not have, they were less than 20/20. We went back and actually retreated all 60 eyes, and only 8 of those eyes were not 20/20. All 8 of those eyes were 20/25, which was one line less than 20/20, but their other eye was 20/20 or better without any correction. And the patients were happy. In that particular study, every patient saw 20/20 or better with both eyes. That was reported in the American Academy of Ophthalmology in Atlanta, Georgia, and the European Society of Cataract and Refractive Surgery in Berlin several years ago. So the retreatment rates are highly dependent on the amount of nearsightedness or farsightedness or your pre-op prescription. We see patients from St. Elsewhere. They sometimes want to get the discount LASIK and things didn't go so well. Those have more complex problems, so there's a greater risk of needing multiple treatments to get them back functioning. Each person heals a little bit differently, which can account for the need for retreatment. And after retreatment, over 99% of patients are seeing 20/20 or better. In that particular study that we did on 1,088 eyes, it was 100% of patients seeing 20/20. So these are just a demonstration of just some of the glare and halos that you might experience after the PRK or LASIK in the first few nights afterwards. Well, how did I arrive in sunny, warm Rochester, New York? I was pretty happy actually in Portland, Oregon. My background is a cornea transplant surgeon, and I would have patients that needed cornea or had corneal transplants. They had perfectly clear corneas, but they couldn't see that well. And the reason was that they had these more complex aberrations that we couldn't measure. Well, the fellow in the upper right-hand corner is Dr. David Williams, and he developed a patented technique that measures all the aberrations of the eye. That was revolutionary, and we now have seen him receive virtually every award, every major award in vision science because of this. Because now, because of the wavefront sensing technology he developed, the intraocular lenses that we design, the LASIK procedures that we do as custom LASIK, and the modifications of that, they're all based on this concept of wavefront technology. It markedly enhances image quality for patients, and that's what actually attracted me to Rochester. I actually tried to recruit Dr. Williams to Oregon Health Science University in Portland, Oregon. He ended up recruiting me here with a $2.5 million grant from Bosch and Loam and the University of Rochester. So I work with a whole group of optical scientists and clinicians at the Flaum Eye Institute to continue to advance laser technology to treat refractive errors and to improve visual performance. So, well, how is this actually done? This is actually taken, an image taken from the Keck telescope, and you can see a bust there. This is the world's largest telescope, and the same technology that Dr. Williams used was actually being used previously by the astronomy community. This is the Keck telescope in the Big Island in Hawaii, and they would take a laser light, shine it up into the stratosphere, and it would bounce off the stratosphere, come back down, and go through the atmosphere, be aberrated by the Earth's atmosphere, pollution or turbulence, and then come down, and then it would go through a series of 100 little lenses. We call those lenslets, and they would measure the aberrations of the eye, and by doing that, they could mathematically determine very precisely the aberrations, and they were sampling at about 20 times per second. Then they had a deformable mirror, and actually that would change shape. And by doing that, they could, in real time, they could actually modify the image so that they could improve the image pretty dramatically and eliminate the atmospheric aberrations. On your lower left, you can see Neptune without the imaging using adaptive optics and wavefront sensing. On the lower right, you'll see once they turn on the wavefront sensor in adaptive optics, the image improves 20-fold. And that same technology, Dr. Williams sort of harvested and brought, sort of minified it and brought to ophthalmology to image the back of the eye. Once we did that, we went from just measuring the 3 aberrations that we typically see on the upper row of the pyramid to being able to treat all these more complex aberrations. This is what we call a point spread function. It's what you see if you have perfect optics, and so patients that typically have some nearsightedness, they'll have a halo pattern. If you have some astigmatism, it looks like that when you look at a point source of light. This is what we've been treating for the past 200 years. When Dr. Williams developed his technology, we were actually able to measure all these more complex aberrations and then go ahead and treat them. And the ones that are really common in the population include coma, which looks like a comet going vertically, or this is vertical coma, this is horizontal coma. This is actually trefoil. It looks like a Mercedes-Benz symbol. It's kind of a 3-lobe version of astigmatism. And the one that's really, really common is spherical aberration, and that looks like a series of rings. We were able to measure those, and then we actually can compensate for those during the laser procedure. This is called customized vision correction, and it dramatically improved the quality of the treatments with LASIK. So we went ahead and did a large clinical trial in Houston, Kansas City, and the University of Rochester. And what we found is during the clinical trial for the FDA, that 60% of the eyes saw 1 or more line better after the procedure on the eye chart than patients could see before the procedure while wearing their glasses or contact lenses. In addition, 40% noted that their night driving was improved. 10% actually noted it was slightly worse, but it wasn't a major issue for them. 50% noted no change, but you were 4 times more likely to notice your night driving was better than worse. This was revolutionary. Before that, there was always just a little bit of deterioration in night driving, basically because we didn't understand making sure that the optical zone sides were large enough. Once we started using wavefront sensing, we were able to compensate for that. In that particular study, over 98.8% of patients were either moderately or highly satisfied. FDA had never seen data like that, and it was really a revolutionary finding once we went ahead and they approved it. None of the patients in the study, this was a large study, 340 eyes, 190 patients, not one patient was dissatisfied with their treatment. The FDA had really never seen data like that before. I went on to develop what's called the University of Rochester nomogram, or the advanced software. With this, over 95% of eyes are seeing 20/20 or better after their primary treatment. I then went on to patent that for LASIK and PRK, and there was a large clinical trial done both in Europe and in the United States. And eventually, after we did the multicenter clinical trial, presented it to the FDA, and they approved it as the only advanced form of customized correction. And currently, it's now used worldwide. So I'm going to turn things back to Dr. Dickerson. He's going to talk to you about some of the logistics in terms of coming to the clinic, and then we'll open it up to your questions after we take a brief tour. Thanks. Dr. Dickerson.
All right. So we'll take our science hats off at this point in time. Hopefully enjoy Dr. MacRae talking with you about refractive surgery. What I'm going to talk about now is basically some logistics about how we get you from where you are listening to all of this online into the practice so that we can actually do that full evaluation. And, basically we need to set some expectations at first so we understand exactly what kind of the goal is. Well, our goal is to basically create a database about yourself, your prescription, your eyes, so we can make sure that you are a good candidate. We do certainly have to have realistic expectations, as Dr. MacRae was going over with you. No surgery is 100%. We cannot promise perfection. And when it comes to whether or not we're going to tell somebody that they're a good candidate, well, we find that about 20 to 30% of patients are not safe candidates. Certainly, we are fussy about all of this, and it's for your own safety. The biggest thing is not having enough tissue for us to actually do the procedure. That's the most common reason. Basically, your cornea is not thick enough for us to say, this doesn't really make sense. It's not safe. But prior to even coming in for the evaluation, there's a couple of things we look for. We want your prescription to have been stable for a few years. And sometimes we've got to go back to old eye exams and old prescriptions, old glasses that you have to help us figure out, have you been moving? Because if you're in a period of time where your prescription is kind of getting a little bit stronger every year, every time you go in to see the eye doctor, we won't, it certainly makes sense to kind of hold off. For myself personally, my prescription really changed, through my teens, my early 20s, and it really stopped changing right around the time I was about 24, 25. And I waited, certainly a few more years after that before I had surgery. But it was good that I did that. My surgery is 13 years ago at this point in time, and it's remained unchanged, which is absolutely what we expect, because the surgical effect is a permanent effect. There's only about 5% of patients that have any change over time. And some of that is just, kind of the unknown. Are you going to ever have a change in your prescription ever again? Good news is if we wait until it's stable, it becomes very unlikely. Age-wise, we only have one age restriction, and that has got to be, be over 18 years of age or older. I think the oldest patient we've done surgery on was 88 or 89 years old. So you can certainly go much further up in the age range than most people would think of. Certainly, we were checking the health of everything, dry eye, all of those types of front surface things that can be going on there. And then, of course, the internal health of the eye. A lot of systemic conditions are really not a huge concern for us as long as they're well controlled. If you have something going on, say like diabetes, and the sugars are not well controlled, well, we want to have those well controlled before we consider doing anything. Once it is well controlled, well, then certainly we can consider our normal procedures. So For those that are contact lens wearers, this is where I have to deliver a little bit of bad news. We need you to actually take them out for a period of time. We need you to kind of go on a contact lens holiday. And it all depends on what type of contact lens you're wearing, because your contact lenses do actually subtly change the front surface of your eye. Actually, some of the ones not so subtly will change the front surface of the eye. For those that just wear your contact lenses daily, you take them out at the end of the day, you don't sleep in them, they don't correct for any astigmatism, then those only need to be out for a week prior to your evaluation. If you sleep in your contact lenses or your contact lenses correct for astigmatism, we need those out for 2 weeks prior to your evaluation. And if you happen to be a patient that wears a hard contact lens, those need to be out for 6 to 8 weeks prior to your evaluation. So let us know if you're a hard contact lens wearer. We will bring you in for a short visit to get a couple of measurements done to make sure it actually makes sense for you to spend that long of a period of time out of your contact lenses. So Fran or Diane or Steve in the chat, you can let them know, and they can make sure that they get you scheduled appropriately. If you are a hard contact lens wearer, just let us know. All right. So the treatment itself, so we go through the full evaluation, which generally takes about 2 hours. You're dilated for the evaluation. You've taken your contact lens holiday. You get through all of that, and we say, okay, you're a good candidate for LASIK or for PRK. What does a day of surgery treatment look like? Well, the procedure is actually pretty efficient. It only takes about 6 to 8 minutes per eye. So you're generally here for the evaluation for about 2 hours. You're generally here on the day of surgery about an hour to an hour and a half. You absolutely want to have somebody drive you home from the treatment. For the evaluation, we do dilate your eyes. So if you don't feel safe driving with your eyes dilated, you may want to consider having somebody bring in somebody with you for the evaluation visit as well. So you've had the procedure. We send you home basically afterwards to rest your eyes for the remainder of the day. We want you to go home, gently close your eyes for the next 8 to 10 hours. We do offer Valium on the day of surgery. That also can help you sleep afterwards. Certainly you can open up your eyes for meals and bathroom breaks. The goal is we don't want you, answering all your emails or, binge watching your favorite show, anything like that. You just want to go home and be able to rest the eyes. We do see you back for a number of follow-ups. We see it 1 day, 1 week, 1 month, and 3 months to make sure everything is good shape. For PRK patients, we do throw in a 6-month visit because it takes a little bit longer to settle down. Most of our LASIK patients are taking the day of, day after off, then returning to most normal activities after that. For PRK, on the other hand, a little bit longer recovery, typically a week away from work to allow everything to heal, for the vision to settle to the point where you've got a really good functional vision. Okay. Now, if anybody's wandered off or wandered away from the screen, this is probably one of our most commonly asked questions here, and it's the how much. So I'll leave this up for a moment. The goal of your evaluation is for us to figure out what you're the best candidate for, and here are the costs associated. Basically, LASIK and PRK with our custom treatments are the same cost. The important thing here for you is the evaluation fee. The evaluation fee is waived for the next 6 months. So we appreciate you coming and listening to us talk all about this stuff. And hopefully we can see you in the next 6 months, and you won't have any evaluation fee. If there is need for treatment, and remember that about 5% of patients do, if we find we need to retreat you in the first 2 years, it doesn't cost anything additional. We do work with Care Credit for financing options if you need to use that. Our staff can help you work through that process. But don't forget your FSA dollars and your HSA dollars. Those funds can also be used for elective surgeries. And this is an elective surgery. Why would you choose Dr. MacRae? Well, with his over 30 years of experience and as a world-leading expert in the field, you couldn't have found a better place to come in for an evaluation and consider this. Technology-wise, we've got one of the finest collections of lasers that help us expand our range of treatments and are so highly customizable for the benefit of our patients. And the last bit has to really be our patient care. You met Diane at the beginning. She is one of our technicians. We have many other wonderful technicians, and we did a little thought exercise the other day and tried to add up the number of years of experience that just our technicians have, and it's over 100 years of experience when you combine all of them. So they've all been working in the ophthalmology field for a long time, working in refractive surgery as well. So if you have any questions along the whole process, feel free to ask any of our staff any questions, and they'll help you along. All right. So we thank you for hanging out till this point in time. We're going to take a very short kind of just crossover break so that we can get the tour going, and Dr. MacRae is going to show you around the office. And then at the end, we'll do some question and answers. Thank you, everybody, for joining, and hope to see you all soon.
Welcome back. This is our entry to the Laser Center. Let's take a tour. Here we go. This is one of our waiting areas for the post-laser treatment. We're going to go to another site. This is one of the rooms that houses our Bosch and Loam laser, and this is the Zemer laser. So there are actually two lasers here. One is the femtosecond laser, which actually creates the bubble layer, which allows us to lift the flap. And then this is the excimer laser, and this laser actually reshapes the cornea so that it can correct nearsightedness, farsightedness, or astigmatism. So we use the femtosecond laser initially. This arm actually detaches and rotates over. The patient's head is here. We actually make the bubble layer, and then we go ahead and then treat the patient with the excimer laser. These are those little antennas that we showed before, and they actually have infrared lights that shine onto the iris. So the other one eye is actually covered, and the other eye is the eye that we're working on. And the laser light is actually shining onto the treated eye. And meanwhile, we're following the movement of the eye very, very carefully with the infrared light. So we're actually able to actually create like a fingerprint of the iris. And if the iris moves at all, then the laser will actually move with it. If the patient moves more than 400 microns, which is less than a half a millimeter, this is a millimeter. So if the patient moves even that much, the laser will automatically shut off. But meanwhile, I'm looking through the microscope. I've got some toggle switches over here on this side, and I have a foot pedal down here on this side as well. So let's take a look at that from this angle. So here I am actually during the actual procedure. The patient's head here, one eye is actually covered, the other eye is looking up into the laser. You see a red flashing light, and all I do to activate the laser is put my foot on the foot pedal, and it activates the laser. If the patient moves more than 400 microns, which is less than a half millimeter, the laser will shut off. But I'm actually fussier than the laser, so I'll be starting and stopping and starting and stopping, just making sure that that tracker is aligning exactly the way I want. I've got some toggles over here. It's kind of like being a fighter pilot. I've got information coming in through the oculars of the laser, and I can manipulate to get the patient super fine-tuned in terms of alignment. During the actual laser treatment, it takes anywhere between 20 and 40 seconds. So the actual laser part is very quick. You'll hear a sound kind of like or which basically is 200 pulses per second. So, and the patients don't feel anything during the actual laser procedure. So the only thing they do feel typically is some pressure from the femtosecond system when we actually create the bubble layer. And that lasts for maybe 15 seconds. But after that, the actual laser treatment, there's no, the patient doesn't feel anything. And if the patient has any sensation of pain, we can always give them some additional numbing drops. We give at least 3 sets of numbing drops during the procedure. The patients ask, well, what happens if I move during the procedure? And if you do, the laser will automatically shut off if you move too much. But I'm actually fussier than that. I'll take my foot off the foot pedal and get the patient readjusted with the toggle switch, get them all set again, and then go ahead, put my foot on the foot pedal, get them, and go ahead and continue the laser treatment. So we're going to go next door to the other room, which is another laser that we work with called the Vizix laser, which can also do LASIK or PRK. So this is the Vizix laser. It was developed by Charles Meyerland, who is a University of Rochester graduate and professor. And then he went on to go out in the industry. He actually was contacted by another University of Rochester graduate, Steve Trokel, who did his undergrad and master's of science degree here at the University of Rochester. He went on to become an ophthalmologist at Columbia University in New York City. Steve Trokel got the idea to use the excimer laser after he read an article by Shevardnadze at IBM. Shevardnadze was developing the excimer laser to etch computer chips for IBM, and Trokel knew that the same wavelength that they were using with the excimer would basically be absorbed by the cornea. So he went and took a group of pig eyes all the way down to the IBM Research Center and with Shevardnadze and basically demonstrated that it does reshape the cornea. He came back to New York City, filed a whole bunch of patents, and then called up his old friend, Charles Meyerland, and they developed this company called Vizix. This laser is the Vizix laser developed by Meyerland and Trokel. It works really, really well for patients with more complex corneas and patients that didn't do, let's say, quite as well at St. Elsewhere. They wanted the discount laser. This laser is really, really good at reshaping the cornea and dealing with more complicated type corneas. So we're going to go into sort of the epicenter of where the wavefront technology was developed. This is actually what we call the wavefront room. And it has a wavefront center that actually was developed by Dave Williams here at the University of Rochester. It used to sit on an optical bench when they first were developing it, which extended from here to the wall with all sorts of prisms and mirrors. And once he patented and licensed it to Bosch and Lohm, they actually, laser engineers actually, the optical engineers reconstructed it, stacked those prisms and mirrors vertically into what we call the Xywave. This measures the subtle aberrations of the eye, and then in combination with another instrument called the orb scan, which measures the three-dimensional curvature of the eye. Those two things actually create what we call the dual workstation, where we take all that information, feed it into a computer system, and then it helps us design an optimal laser treatment. So when I first came here, Bosch and Lohm actually bought the patent rights to the Xywave system, and then they also bought a diagnostic equipment company called Orbtech, and Orbtech had the sort of the leading corneal topographer at that time, the orb scan. So we worked for years to actually combine these instruments together to sort of improve the outcomes with using wavefront technology. So this is another instrument that is called the iDesign. It was developed in conjunction with the Vizix laser that we just looked at. And it has a very, very sensitive wavefront sensor, which can measure very subtle aberrations. So in patients with more complicated corneas, we use the iDesign. We can measure the complicated curvature changes and then actually program that into the laser to correct out those subtle abnormalities.
All right. Well, we're going to thank Dr. MacRae for just taking us on a wonderful tour of the office and what we've got up next for you. And we'll certainly get to your questions after this. We've got a patient who had surgery about a week ago who wanted to come on and actually talk about how things went. So I'm going to let Max talk about his experience on how things went on the day of surgery, how things are going for him now. So I'll turn it right on over to you, Max.
Wonderful. I appreciate that. And thank you very much for having me. Yeah. And I mean, I was able to get up and use the bathroom. I mean, that wasn't an issue. I then just sat right back down and closed my eyes, ate dinner with the family. So that wasn't an issue at all. And the not touching your eyes is key. But I think day 4 or 5, I had a slight itch right here and I just happened to slide ever so slightly. And I could tell that your eyes are incredibly sensitive. So that would be the one piece of advice is don't even think that you're going to be rubbing your eyes or touching your eyes, and you won't even want to do that.
Yeah. Your eyes are a little bit more sensitive for that first couple of weeks, and then that kind of fades away. So, well,
Max, what was your vision like beforehand?
Oh, okay.
You want to talk about that? Kind of comparison before and after?
I mean, I couldn't see the biggie on the chart. So I think it's what, 2400. I mean, my contacts were 4.25. So I know there are plenty of people worse than me, but it definitely, I mean, I couldn't go about my day without glasses or contacts in. And I always felt that with my glasses, it was like I was watching a TV set because the edges were still really fuzzy. So I mean, I was doing contacts 7 days a week for the last 18 years at this point, and it, it is magical. I mean, there's no other word to say it, to go from not being able to see your computer, your phone, or the face in front of you unless your noses are touching, essentially, to now waking up the morning after and seeing. I mean, I remember I rolled over at like 3:30 to use the bathroom, and I looked at my phone to check the time, and I almost cried because I could see my phone, and it's life-changing. It really is. I mean, I recommend it to everybody that I talk to.
It's neat. Yeah. Terrific. Well, Max, we really appreciate you taking the time, and
I appreciate you doctors being so good. So thank you first and foremost. I really appreciate that.
Well, thank you.
You're welcome. Have a wonderful rest of your day.
Okay, you too.
Thank
And
you.
thanks again.